Welcome to the Lymphoma Research Foundation's update on Waldenstrom Macroglobulinemia webinar. I'm Jenny, and I'll be the moderator for today's call. During today's call, you will hear from an expert speaker, and you will have an opportunity to ask questions. If you have questions during today's presentation, you can ask them at any time in the Q&A box on the webinar. As a reminder, this webinar is being recorded. At the end of a program, a link will appear on your screen. Please follow this link to complete an evaluation of this program and gain certificate of attendance. If you are listening by phone, this link will be sent to your email at the end of the webinar. And now I'm pleased to introduce Jessie Brown. Jessie Brown is the Associate Director of Patient Education at the Lymphoma Research Foundation. Welcome, Jessie.
Thank you. And thank you to each of you for taking the time to join us on today's update on Waldenstrom Macroglobulinemia webinar. We'd like to thank our sponsors of this webinar, Pharmacyclics and AbbVie Company and Janssen. Today we have callers from 15 countries and 44 states across the U.S. Access to expert disease information is so important, and we are thrilled to be able to bring you this educational program. Before I turn the program over to Dr. Castillo, I want to share information with you on the Lymphoma Research Foundation. At this time, I'd like to show you a short video that better explains the work that we do in striving to impact patients, caregivers, and healthcare professionals as we work to fight lymphoma.
My name is Juliana Fuller, and I was diagnosed with follicular lymphoma in 2011. The questions that came to my mind at that time were not just about treatment and about survival, but also, how does a young adult face this? And from the very first moment that I was in contact with the Lymphoma Research Foundation, I was so impressed by the professionalism and just the evidence-based information that was given.
For a lymphoma patient, whether it's newly diagnosed or relapsed, the Lymphoma Research Foundation is an invaluable tool. It's a fantastic resource, number one, for patient education, whether it's online videos, online information, access to clinical trials. Patients can also meet other patients with similar shared experiences as well.
When someone contacts the LRF helpline, we provide them with information about the disease itself, including information about the most common lymphoma subtypes, and we have resources that are specific to these, including fact sheets and booklets. We also provide them with information about treatment options, as well as clinical trials, and whatever their needs might be financial assistance or peer support, for example. One of the ways that we connect individuals with the larger lymphoma community is through our Lymphoma Support Network. This is a peer support program where we match patients, survivors, and caregivers with others who have been through a similar experience. We find that there's certainly something to be said about being able to connect with someone who has walked down a similar path and who can share their own experience with that individual.
I will often refer patients to the lymphoma.org website as well as their app. Both of them provides useful information for whether it's the big picture or also aspects and information for the individual patients.
My involvement with the Lymphoma Research Foundation, currently as an ambassador, as an FDA patient representative, and sat on oncologic drug advisory committee panels for lymphoma treatments. It's what I owe to the team that helped cure me. It's what I owe to the lymphoma community.
Even since my diagnosis, there's been so many new treatments out and even changes in recommendation of what frontline therapies should be. To say how LRF has impacted me, it just has been huge. I felt this relief of anxiety.
The resources that the Lymphoma Research Foundation provides to patients are really invaluable. Coming into the foundation allowed me to do what I need to do as a survivor, and that is to support the new patients that we have, to support the mission to eradicate lymphoma and serve those touched by the disease.
I really hope you'll take advantage of some of the great resources and services that LRF provides. If you have questions regarding what you saw in the video, or if you need information about relevant treatment options and supportive care resources, you can reach out to the Lymphoma Research Foundation through our website at lymphoma.org or by calling our helpline at 1-800-500-9976. Without further ado, we have a wonderful program planned for you today, and I'm honored to introduce you to Dr. Jorge Castillo. Dr. Castillo is a medical oncologist with Dana-Farber Cancer Institute, where he's a clinical director of the Bing Center for Waldenstrom Macoglobulinemia. He also is an associate professor of medicine at the Harvard Medical School. His research and clinical interests revolve around Waldenstrom's, and he is a well-known expert in the field. Thank you so much, Dr. Castillo, for presenting today.
Thank you. Thank you very much, and good morning to everybody. Thank you for joining us on this webinar, in which I will be speaking on current and future treatment options for patients with Waldenstrom's macroglobulinemia. This lecture will be about 40 minutes or so, and then we'll give you options for sending me your questions. Please keep your questions as general as you could have, and you could be, very specific questions are difficult to address in this context, and not completely helpful to the other members of the audience. So let's start with this presentation. Initially, I would like to discuss the criteria that I use in my clinic to actually formally diagnose a patient with this condition called Waldenstrom's. A bone marrow biopsy is necessary in most cases, and that bone marrow examination should reveal the presence of a lymphoplasmacytic lymphoma. It's a type of indolent, slow-progressing B-cell lymphoma, and 99.9% of the patients would have bone marrow involvement, and that's why we go there to find it. These malignant cells, these lymphoplasmacytic cells, do secrete a protein called IgM. We all have IgM, but no more than 240 milligrams per deciliter in most laboratories. Patients with Waldenstrom's tend to have higher levels of IgM, and in our clinic we see anywhere from 250 all the way to 16,000. The average is about 3,000 to 4,000. Interestingly enough, the level of IgM doesn't really tell me how sick the patient is or how symptomatic the patient will be. So every patient should be evaluated in a very personalized manner. Finally, in a patient who has a lymphoplasmacytic lymphoma in the marrow and has an IgM monoclonal protein in their blood, we look for a mutation in the malignant cells, a mutation in an MYD88 gene. We all have that gene, but in most of us who do not have Waldenstrom's, this gene is not mutated, and that's called wild type. In this situation, over 90% of patients with Waldenstrom's, we have tested several hundreds of patients with Waldenstrom's in our clinic, they tend to have this mutation in this gene called MYD88. So if a patient comes to my clinic with these three factors, I can safely say the patient has Waldenstrom's. Now, Waldenstrom's can be asymptomatic in about a third of the patients that come to my clinic, and in those situations, treatment is not necessary. Having said that, Waldenstrom's can provide other manifestations, and these manifestations could be very different from one patient to the next. The most common manifestation continues being anemia by replacement of the marrow by these malignant cells, not allowing the other normal cells from producing what they are supposed to produce. But these patients can also have hyperviscosity, they can have low platelets, they can have cold agglutinin disease, they can have neuropathy because of the Waldenstrom's. A rare proportion of patients have amyloidosis. They can have renal involvement, but much less common than in myeloma. They can have pleural effusions, and very rarely some patients can have brain or spine involvement by the Waldenstrom's called Bing-Neill syndrome. As you can see here, the manifestations of Waldenstrom's are very diverse and sometimes difficult to understand or diagnosed appropriately. So seeing a specialist is almost always recommended in these settings. Now, we don't have to treat everybody at diagnosis, as I mentioned earlier, for a number of reasons. Waldenstrom's is an incurable condition as of today, and our treatments not only induce toxicity, but also can promote resistance. Now, there is no evidence of any study so far that by treating patients earlier in the course of the disease, we actually prolong their survivals. And patients with Waldenstrom's enjoy decades of life. I would say in my clinic, more than half of the patients have a normal life expectancy. On the right, we can see a study in which patients with Waldenstrom's but without symptoms were followed over time. And you can see at the 2-year mark, about 30% of patients needed to be treated. But if you follow that line all the way to the 10-year mark, you will see that about 80% of patients will need to be treated. By 20% of patients did not need treatment 10 years later, which means that 1 in 5 patients with Waldenstrom's might not need to be treated for over 10 years. And I think it's a good idea to provide the patients with a good quality of life without exposing patients unnecessarily to treatment if they're going to be on that group of patients who might not need treatment for many years. Now, when we decide to treat, we usually base that decision on some specific guidelines. Anemia, as I said, is the most common one. Hemoglobin usually below 10. Platelets below 100 can be another reason. Patients with symptoms of hyperviscosity like nosebleeds or gum bleeding or blurred vision or headaches or retinal changes on the vessels can also be another reason. Moderate to severe neuropathy that is progressing and affecting the patient's activities of the daily living, another reason. And as you can see here, the common denominator is actually symptomatic disease, symptomatic lymphadenopathy, symptomatic enlargement of the spleen or the liver, symptomatic effusion, symptomatic cryoglobulins, or symptomatic cold agglutinins. And we say symptomatic because we do have patients who have a little bit of lymph node enlargement, who have a little bit of cryoglobulins, a little bit of cold agglutinins, or very mild anemia, or very mild neuropathy, but these are not affecting the patient's quality of life. In those settings, it's best to keep the patients untreated so we do not promote resistance or cause more toxicity that the patients are not experiencing at the time. So when we get to a point in which a patient needs to be treated, we have several treatment options, and I'm going to review the most common ones that we use currently and later on the future treatment options that will be coming up shortly. The classic approach to Waldenstrom's includes chemoimmunotherapy, which is a combination of chemotherapy and an antibody called rituximab. Rituximab is an antibody against CD20. We've been using rituximab for Waldenstrom for the last 20 years, and chemotherapy for Waldenstrom's also for about 20 to 30 years. So we have a lot of experience with this regimen. Highly effective regimens, as you can see there. The overall response is anywhere between 70 and 90%. The very good response is between 20 and 40%, with time to progression anywhere between 3 and 6 years with all these different types of treatments. So highly effective treatments. However, they do have some potential issues, as we will talk about a little bit later. One of the most commonly used regimens at this time is bendamustine. This was compared to a more aggressive regimen called R-CHOP in a study by the Germans some years ago, and it showed to be more effective and less toxic than the multi-agent chemotherapy. So bendamustine and rituximab has become one of the standard treatments for patients with Waldenstrom's. The main concern there, from my perspective, is about a 1% risk of developing a secondary leukemia because of the exposure to chemotherapy. Cyclophosphamide is another chemotherapy extensively used in patients with Waldenstrom's, very much used in Europe. Is widely available, is very affordable, but very highly effective as well. And again, some nausea, some vomiting, some decreased blood counts, and the risk of secondary leukemias also applies for these agents. We have another family of medications called proteasome inhibitors, which we actually borrowed from the myeloma experience. And there are 3 proteasome inhibitors in the market at this time. We have bortezomib, which is the longest, I think probably 12, 15 years of experience with it. Carfilzomib, a little bit more recent, probably about 6 or 8 years of experience. And most recently, ixazomib, which is about 5, 6 years of experience. And all these agents, in combination with rituximab and steroids, have shown to be very effective. As you can see there, the responses between 80 and 90%, with major responses between 60 and 70%, and progression-free survival between 4 and 6 years. Bortezomib is probably the one that we have more experience with, very effective, very rapidly effective. The beauty about these agents is because these agents are not chemotherapy, they don't have the risk of secondary cancers. However, they do have other problems. Bortezomib is injected under the skin, usually once or twice a week, and that treatment can be associated with some nerve ending damage. Some patients can have some numbness or tingling, burning, or pain on their fingers and feet. Most of the time, this is reversible, but there are some situations in which we would not like to use this, like in patients with neuropathy, for example. It can make the neuropathy worse. All these regimens can cause shingles, and therefore patients should be on an anti-shingle treatment throughout the duration of the treatment. Carfilzomib is the second one came out. It's actually intravenous. It's also given weekly and also in combination with rituximab, highly effective, non-neuropathy, which is a good aspect of things, but it can give patients, specifically patients older than 65, higher risk of cardiac and lung issues, as well as increased glucose and cholesterol and hypertension. Ixazomib is more recent. It's actually a pill. It's a pill that is taken on a weekly basis, very effective as well, and the reactions are actually much more moderate than with bortezomib or carfilzomib. Very, very minor neuropathy, no cardiac or pulmonary side effects that we know about, but because it's a pill, it can cause some rash, it can cause some gastrointestinal issues, but again, no risk of secondary leukemia with this agent either. So how do we know which one is better? And the question is probably we will never know. And the reason for that is because there's not a clinical trial comparing these agents, and I don't think there will ever be. So in our clinic, what we did, we collected the data from patients treated with bendamustine, bortezomib, and cyclophosphamide in a retrospective study, and we basically compared them side by side. These are patients who were never treated. This is the first treatment they ever received, and we looked at the progression-free survival and the overall survival. As you can see, the graphs, the curves are almost overlapping, telling us that really there's no major differences between these regimens. For a while there, we're recommending maintenance rituximab, which is giving rituximab alone once a quarter for about 2 years after completing either chemotherapy or protein inhibitors with rituximab. And we saw some benefits in terms of progression-free survival and overall survival. This is a study from us. Also, the Mayo Clinic did another study showing very similar outcomes. But then a recent study by the Germans presented last year showed that really there was no benefit. This is a prospective study, and we tend to believe prospective studies or trust prospective studies have been more than retrospective studies. So in this study specifically, there was no benefit of the addition of rituximab after completing bendamustine and rituximab in terms of progression-free survival or overall survival. Having said that, only patients who got at least a 50% decrease on the IgM, that is a partial response, were included here. So patients with more superficial responses, what we call minor responses, between 25 and 50% decrease were not included here. So those patients might benefit from maintenance. Also, during the presentation, patients who were older than 65 and patients with more aggressive disease based on the prognostic scoring that we have might actually have benefit from maintenance. So there's, I think, a group of people who might benefit from this concept of maintenance rituximab. So what is new? I mean, our group detected this mutation in NYD88 in 2012 and reported that at that time. Since then, and you can see the study by Zhu up there, that's the study from our group, and then multiple other studies from France, Italy, Spain, Greece, and Austria, Japan, India, and China, just to name some of them, have shown to have consistent reports, and therefore over 90% of patients, in general terms, 90% of patients with Waldenstrom's can have a mutation in NYD88, and I think that's an important discovery that will advance the science, as you will see later on. We have also detected another group of mutations in another gene called CXCR4. And Dr. Hunter from our group also reported this initially about 27%. And further validation by other groups in Europe and in Asia also have shown that anywhere between 25 and 30% of patients with Waldenstrom's can have these mutations. Why is this important? Because I think biologically speaking, and this is not trying to confuse you, but just to understand, that as a scientist, we like to target agents. So understanding the biology of the disease, of how the disease signals down inside the cell, that provides us with targets. And whenever we understand the targets, then we can actually use medications to target it. So in this situation, for example, on the left, we see a number of different issues. That's actually the MYD88 pathway. As you can see there, BTK is a very important aspect. It's actually circled right there with the red. It's actually a very important component of the activation pathway of the NYD88. And therefore, based on that, we thought that trying a study with a BTK inhibitor that was actually available in the market would have been a good idea. So we actually did a study with a BTK inhibitor called ibrutinib. This is an oral agent. It is one pill that patients take on a daily basis. And there have been now 3 studies on that, on the use of that agent, showing high efficacy with this regimen. Again, these are regimens that do not include chemotherapy, they do not include injections or infusions. It's all pills that are taken on a daily basis. The overall response rate between 90 and 100%, and the major responses between 70 and 80%, with progression-free survival, again, very long, as we have seen with chemotherapy, but not chemotherapy. So interestingly enough, the mutations seem to play a role on how well patients do respond to ibrutinib. In the column in the middle on the table, you can see the patients with CXCR4 mutations. That's about 1/3 of the patients. We can see that the response rate, if you don't have CXCR4 mutations, 100% versus 86% if you have the mutations. The major responses are 97% versus 68% if you have the mutations. And very good responses, which is a 90% decrease on the IgM, goes from 47% to about 10%. So we know that the depth of response gets affected depending on which mutations you have. And that really tells us that we should potentially understand those mutations and know these mutations if we are thinking about getting treated with ibrutinib, for example. On the right, we can see how patients without CXCR4 mutation have the best outcomes. 75% of patients continue without progression at 5 years, while half of the patients by 4 years, half of the patients with CXCR4 mutations already progressed by four years, and patients without mediated mutations progress usually within 2 years. So the mutations play a really important role in responding to ibrutinib. Now, for that, there was another study that came out a couple of years ago in which we participated as well. This is a study in which ibrutinib and rituximab were compared against rituximab alone. This is one of the few randomized studies that I will mention in this lecture. And we saw that the combination of ibrutinib and rituximab, not surprisingly, induced deeper responses, faster responses, and longer responses than rituximab alone. Now, the problem with that study is that we don't have an arm of ibrutinib alone. So I know that adding ibrutinib to rituximab makes rituximab better, but I do not know if adding rituximab to ibrutinib makes ibrutinib better. The ideal design of this study would have been having a third arm of ibrutinib alone, but that did not happen, and I don't think this is going to happen. Therefore, we do not know really what the benefit of adding rituximab to ibrutinib is. This is just the different studies that I just mentioned, and that you can see throughout, there are no major differences in terms of the outcomes or the responses between these patients. So I don't think we can safely say at this time, or categorically say at this time, that adding rituximab to ibrutinib makes ibrutinib better. And that is a contentious aspect of the care of patients with Waldenstrom's at this time. Now, ibrutinib has its own problems and own side effects. I think the most important one is arrhythmia, as you can see on the star there. This arrhythmia is usually what we call AFib, or atrial fibrillation. That is a very common arrhythmia in patients without Waldenstrom's and in patients who are not on ibrutinib. But it seems to us that the risk of having this arrhythmia increases on ibrutinib. About 10% of patients do develop these problems. Older patients or patients with history of heart problems tend to have a higher risk of developing these arrhythmias as well. So we need to be aware of that. Blood counts can decrease, bleeding can occur sometimes in these patients, and we need to be very mindful of those side effects as well, because they are just a little bit different of the side effects that we are classically associated with chemotherapy that we know about, like vomiting or losing your hair and things like that. So this different side effect profile. The other difference is that this treatment with ibrutinib is indefinite, meaning patients need to be on this pill indefinitely for as long as the treatment works and for as long as there is not a intolerable toxicity or unacceptable toxicity. Patients should continue on treatment. And we do have patients who have been on the initial study from 2012 who are still on ibrutinib today, 8 years later, and continue on ibrutinib because they continue doing well. So like everything else, there's going to be a group of people who respond really well to it, a group of people who respond a little less well to it. Some people will have some side effects, some people have no side effects. And obviously, it's all about personalization of therapy at the end of the day. So as you can see, this is just a summary slide of all the different treatment options that we have in patients with Waldenstrom's, and again includes chemotherapy, protein inhibitors, BTK inhibitors, and antibodies as well. So what are new BTK inhibitors? We actually have 2 in the market. One of them is called acalabrutinib. The data was published earlier this year. This is a twice-a-day medication instead of once a day. Very effective, as you can see there. The response rates anywhere between 90 and 95%, with very substantial progression-free survivals, at 2 years, anywhere between 80 and 90%. The side effects are similar, AFib maybe about 5 to 6%. There's still a little bit of bleeding, still some blood count drops. Headaches is a big issue with acalabrutinib in our practice. Seems that patients need to have their coffee on a daily basis. So actually with coffee, the headaches actually do get better for some reason. Some infection risk as well. So the side effect profile of acalabrutinib seems to be very similar to ibrutinib. The other agent is called zanubrutinib, that just got approved for mantle cell lymphoma a few months ago, and this paper just came out a couple of months ago comparing zanubrutinib versus ibrutinib. This is the only other randomized study that was done in these patients with Waldenstrom's, the ASPEN study. We also participated on this study, and we can see here that the response rates are similar. The deep responses are maybe a little bit just a touch higher with zanubrutinib than ibrutinib, but when you look at the progression-free survival, really there are no major differences between the two groups. Where do we see a difference, though, is in the side effect profile. It looks to me that in terms of the atrial fibrillation on the right upper side, we can see here how the risk of atrial fibrillation is higher with ibrutinib than with zanubrutinib. However, on the bottom, we can see the risk of decrease on the neutrophil count, which is the white blood cell count that protects against infections, seems to be a little higher on zanubrutinib than ibrutinib. One more reason advocating for personalization of therapies in patients with Waldenstrom's. Now we're talking about new BTK inhibitors. And why am I talking about that? Because in patients who develop resistance to BTK inhibitors, meaning patients are on BTK inhibitors, ibrutinib or zanubrutinib, and 3, 4, 5 years later they start losing the response, most of these patients do develop a mutation in BTK, or a mutation in another gene called PLC gamma 2. And these, could potentially tell us that, why these patients do not continue responding to these medications forever. So there's a new group of medications that target BTK but do not pay attention to the mutation. So they have a different way of targeting the BTK without being affected by the mutation that was developed because of the exposure to the prior treatment. And there are a couple of agents that we are evaluating at this time. One of them is called LOXO 305, and this is data presented last year. No Waldenstrom patients were here, but there were other patients with mantle cell lymphoma and CLL, conditions that classically respond very well to BTK inhibitors. And these patients actually had some BTK mutations. And despite that, there were actually responses on 7 out of 8 of these patients. So very early evidence of efficacy. Similarly, there's another agent called ARQ-531. They are so early that they don't even have a name. They have only letters and numbers. And again, 40 patients were treated. There were no Waldenstrom patients here, but also CLL patients and mantle cell lymphoma patients. Some of these patients were already refractory to ibrutinib, and they were able to see responses on these patients as well. So more data to come up with these new BTK inhibitors that might work even when patients develop BTK mutations. CXCR4 becomes now a target for treatments based on the discovery of the mutation. And this is an initial study that we did a couple of years ago, ibrutinib and an antibody against CXCR4 called ulocuplumab. This antibody was given intravenously. We have not formally presented results from this study yet, and I think that will be presented later this year, and we will update you with the results of this study. But that I want to just say that I think this study will show that targeting CXCR4 is actually a way to go, specifically in Waldenstrom patients with CXCR4 mutations. Because of this, we were very interested in pursuing another agent that targets CXCR4. This is a pill form treatment called mavorixafor. So this study just started. We have about maybe 2 patients enrolled on this study. There are 18 patients to be enrolled in this study. And in this study, we're going to be giving ibrutinib in combination with mavorixafor. So one pill as a BTK inhibitor, another pill as a CXCR4 inhibitor, and then we will treat those patients and see if they respond as well as they should be, even though they carry CXCR4 mutations. So these, the results of this study, I don't think will be available this year or maybe the next, but biologically speaking, it does make a lot of sense to see how these combinations will do in the future. We have another family of medications called BCL2 inhibitors. I think the main member of this family is this medication called venetoclax. Venetoclax is already approved for chronic lymphocytic leukemia and acute myeloid leukemia by the FDA in the United States already. There's a lot of data suggesting that it's very effective on those agents. There's another study on mantle cell lymphoma actually showing high efficacy. So based on all that, we decided to run our own study in patients with Waldenstrom's. And this is a study that has been presented in a couple of meetings, and we are currently working on the actual manuscript that hopefully will be published before the end of the year. But this is data that is public, and that's why I can share this with you. We actually exposed 31 patients to venetoclax. More than half of the patients actually had CXCR4 mutations, and about half of the patients also were previously exposed to BTK inhibitors. So this is a population of patients that is very interesting to evaluate. And we could see here that the age was around 66 patients between 39 and 80 years of age. They were all previously treated. IgM about 3,500, that was the average. Hemoglobin around 10, and a platelet counts of 220 in average. 30% of patients had lymph node enlargement, about 20% had spleen enlargement. And this is what we call the waterfall graphs figures. So each bar is one patient, and the longer the bar, the better the response. So you can see how on the right you have the longest, and we have the ones on the left are the more superficial responses. So if we cross a bar around 25%, which is between 20 and 30, the minus 20 and 30 there, we can see that 90% of patients actually responded, or more like 80% responded to venetoclax. If we cross a bar around 50%, we can see that about 70% of patients had a major response. And if we cross around the 90%, we can see that about 15-20% of patients had a very good partial response. Now, interestingly enough, we can see there that the gray bars are the patients without CXCR4 mutations, and the red bars are the patients with CXCR4 mutations. And we can see that it doesn't look that CXCR4 mutations actually affect the depth of response to venetoclax, which is not the same for patients who were previously exposed to ibrutinib or BTK inhibitors. If we have here the orange bars are prior BTK inhibitors. They are all more clumped on the left, which are more superficial. And the patients without prior BTK inhibitors are on the right with the blue marks. So we can surmise that prior exposure to BTK inhibitors might provide some resistance to patients treated with venetoclax based on the results of this study. Obviously, this was data presented last year, so we will have more updated information to provide with the manuscript later this year. This is the progression-free survival at 18 months on venetoclax, 82%. We do see some cytopenias or low blood counts as one of the major problems here, low white blood cell counts, anemia, very mild diarrhea. Otherwise, we have not seen any neuropathy. We have not seen IgM flares. We have not seen tumor lysis syndrome, which is a concern with venetoclax. We have not seen secondary cancers. So far, a relatively benign side effect profile for this agent. And based on that, we are now running this clinical trial combining ibrutinib and venetoclax. This is a study that essentially is going to be looking at this combination in about 50 patients who were previously untreated with Waldenstrom. So this is a frontline treatment. There are a number of reasons why I'm excited about this study. Number one, I think biologically speaking, the combination of a BTK inhibitor and a BCL2 inhibitor makes a lot of sense. We have actually data from our laboratory showing that when we use these two agents together, they do promote synergism, which means the effect of the addition is actually higher than the effect of each of the agents separately. So that is highly encouraging in this population, number one. Number two, this is a study with pill-only treatments. There's no intravenous treatments, there's no injections, it's all pills, right? Which I think is a highly interesting concept as well. Number three, there's no chemotherapy here at all. These are all targeted agents. And number four, we are going to give treatment for 2 years, and then all the treatments will be stopped. So there is a chance that these patients will not need to be treated indefinitely, right? So I think it's a very interesting study to participate. If you are considering a frontline treatment for Waldenstrom's, feel free to get more information on this study and let me know if you actually have any interest on this. There's a clinicaltrials.gov registration there, NCT number as well in the slide. I think we have already 12 patients enrolled. We have a goal of 50 patients to be enrolled. They're all treated at Dana-Farber at this time. So as you can see, we are moving forward with non-chemotherapeutic approaches, combining, targeted agents that have a strong scientific rationale. I think that is the best way to advance the science and provide treatments to patients with high degree of efficacy, lower toxicity, and also, finite duration. And with that, I really want to thank you for your attention, and I will remain available for any questions you might have. Thank you very much.
Great. Thank you so much, Dr. Castillo. So we'll now begin our Q&A portion of the program. Just as a reminder, please keep your questions as general as possible so that the entire audience can benefit from your answers. If you'd like to ask a question, please submit your question through the Q&A box on your screen. We'll take as many questions as possible, but if you have a question that does not get answered, you can always reach out to LRF's helpline at 800-500-9976. Now we have our first question from online. What additional testing besides the biopsy is necessary to determine what type of treatment is necessary if treatment is required?
Yeah, that's a good question. So I think the genomic profile is important, right? As we mentioned already, and that information I think is best obtained from the marrow. There are some studies in which has shown from us actually that we can get that genomic information from the blood as well, but it's not as reliable. So as of today, the bone marrow material remains the best place to get this information from. Now, we also look into having to account, besides the genomic profiling, we have into account the patient's symptoms. For example, if a patient has neuropathy, we will be much less likely to recommend treatments that could potentially cause neuropathy, right? So the comorbidities of the patient are very important. The patient's age is also important. For example, if a patient is 50 or 55, I will be probably less likely to recommend a chemotherapeutic approach that could increase the risk of having a secondary leukemia in a 55-year-old man or woman by about 1 to 2%, right? So, for example, if a patient has already a history of arrhythmias or heart failure or heart attacks, then I probably will be less likely to recommend either ibrutinib or carfilzomib. So I think the patient's age, performance, comorbidities, as well as the genomic profile are important aspects to look into to make these decisions. Now, there's another aspect that is not biological that we need also to have in mind is the cost. Some of the oral agents are actually very expensive, and the coverage sometimes could be problematic in some patients. So that has unfortunately become also one of the aspects to look into, before treatment is recommended, to see if the treatments are actually affordable by the patient. So multiple aspects to look into, and I think the right decision is the one that has all those aspects, evaluated before providing.
Okay, great. Thank you so much. Our next question is, would the flu shot be appropriate for any Waldenstrom patient newly diagnosed or undergoing treatment?
I think the short answer is yes. The long answer is that there are some concerns that the flu shot might not be as effective in patients with Waldenstrom's who have received chemotherapy or actively receiving chemotherapy or actively receiving rituximab, and that is potentially true. Having said that, I don't think there's any data suggesting that the immune response is zero. So if you don't get the vaccine, the response will be zero. So if you get the vaccine, there's a chance that it might be lower than 100%, but I think it's very likely that it will be higher than zero. So I think, in my opinion, as long as there is not a safety concern with the vaccine and maybe just some efficacy concerns, I will still recommend vaccination for the flu shot, and that also applies for the shingles shot, and that also applies for the pneumonia shot for our patients to try to keep them, the best protected they can be.
Great, thank you. Our next question comes from online. Are there any factors that can increase one's risk in getting Waldenstrom's?
Yes, but nothing that could be modifiable. So we know that patients, who are older have a higher risk of developing Waldenstrom's. So just the fact that you're alive in this world a little bit longer, then the risk of Waldenstrom's also increases, but there's nothing you can do for that. There's no pill for aging, unfortunately. Now, we know also that men have a double the risk than women of having Waldenstrom's, but again, not much you can do about that either. The other one is there's some ethnicity here, predilection as well. So it looks like Caucasian populations have a higher risk than African Americans, Asians, or Hispanics. And within that population, it looks like the Ashkenazi Jewish population, or with some ancestry, have a little higher predilection as well. So, but again, not much you can do about your own ancestry. So I would say those are the most common. Also, the other one is familial history of blood cancers or Waldenstrom's. You have a sibling or a parent or a child with Waldenstrom's or a blood cancer, that also increases the risk of other Waldenstrom's and blood cancers as well. But again, none of those are modifiable at this time.
Thank you. Our next question is plasmapheresis sufficient enough to treat Waldenstrom?
My answer is no. I think plasmapheresis, the only role of plasmapheresis at this time is if we have a patient with symptomatic hyperviscosity, that is having nosebleeds or having retinal bleeds, and their eyes are affected, or patients are having some stroke-like symptoms because of that. Then at that time, I think plasmapheresis is very important. If the patient is having acute neuropathy, and by acute I mean the neuropathy that develops within days to weeks, rather than months or 2 years, could potentially benefit from that. And also patients who have either cryoglobulins or cold agglutinins causing symptoms, I think all those patients might benefit from plasmapheresis to bring down the IgM and help with managing the symptoms. Having said that, that is not a definitive treatment, because within 3 to 4 weeks, the numbers are going to go back up again, and the symptoms will come back. So, some people can say, well, I can have a plasmapheresis on a monthly basis for the rest of my life. Well, if that would be so simple, right? Because they need to be, central lines need to be placed. There's some issue with bleeding, clotting, infusion reactions, increase in blood pressure, decrease in blood pressure. But the most important aspect is we're only removing the IgM. We are not affecting the underlying disease. The underlying disease continues progressing, and we are not doing anything about that just by removing the IgM. So the current recommendation is do the plasmapheresis if needed, but always as a bridge to a more definitive treatment.
Great, thank you so much. Our next question is, what are IgG levels that are common in Waldenstrom? Is it lower or higher than normal levels?
So it's typically lower. About half of the patients with Waldenstrom's have low IgG levels just at the time of diagnosis, even without previous therapy. And from the other half, about 2/3 will actually develop low IgG levels because of the treatment. So in my population with Waldenstrom's, I would say 75 to 80% of patients have low IgG levels. Now, the large majority are not symptomatic from that. Even though the IgG levels are low, these patients are not symptomatic. They are not having recurrent infections. Their immune systems are working fine. So in that setting, there's no interventions to be taken. Having said that, if somebody has low IgG levels and are developing recurrent sinusitis, bronchitis, pneumonias, ear infections, or things like that, at that time we could potentially treat those patients with IgG infusions. But again, if I take all my patients in my clinic, I would say from all the patients with low IgG, maybe only 10% or 15% will need IgG treatments. The large majority will be okay.
Next question is, are there any dermatological conditions such as dermatomyositis associated with Waldenstrom macroglobulinemia?
Nothing that is formally described. There is a condition called cutaneous macroglobulinosis, in which IgM actually deposits on the skin. But I mean, in my database of about 3,000 people, maybe a handful of people have had that problem. The other condition is a condition called Schnitzler syndrome, in which patients have these hives that come and go on their skin, and that requires all these things require biopsies to make sure that that's what it is. Now, dermatomyositis is an autoimmune disease in which the skin and the muscles of patients are affected by attack by their own immune system. I think autoimmune conditions are more prevalent in patients with any lymphoma, and that includes Waldenstrom's. And the opposite is also true. The prevalence of lymphomas is actually increasing in patients with autoimmune diseases. So it's hard for me to say that there's a causal effect. I think there's more of a relation, biologically speaking, but I cannot tell at this time, I cannot say that dermatomyositis is a consequence of Waldenstrom's.
Thank you. Your next question is, you mentioned treatment by specific mutation. Does this mean there is a genetic testing for mutations, or how do you determine specific mutations of Waldenstrom, such as MYD88 and CXCR4?
Yeah, so at this time, those are the two mutations that we have not only detected, but also they have some clinical implications. We have detected many more mutations in patients with Waldenstrom's. The problem is that we do not know what do they mean in terms of, how to take care of a patient. There's a new mutation that is coming up called a mutation in a gene called T as in Tom, P as in Peter, 5-3, TP53. That mutation also is seen in myeloma and CLL and other conditions. And we are also seeing in about 5 to 7% of patients with Waldenstrom's. So we're still trying to understand what it means. Maybe there's some resistance to chemotherapy when patients have that mutation. But again, we have other mutations in CD79B, ARID1, so many other mutations, but we do not know yet what they mean. So even though we test them, we find them, at some point we will analyze and see if they, they actually mean anything, or we need to do anything different to patients because of the presence of those mutations. So those are not clinically relevant mutations as of now. So the only mutations that are that we are considering, clinically relevant are MYD88, CXCR4, and possibly TP53.
The next question is, for patients who have CKD as a result of Waldenstrom, would you change treatment or recommend something in particular?
Yeah, so I mean, so in those contexts, for example, that's where bortezomib or ixazomib tend to be really good agents for patients with kidney problems. For bendamustine, for example, we will need to, it works very well, but we'll need to decrease the dose, and there's maybe some issues with toxicity there. Cyclophosphamide works really well on patients with CKD. Ibrutinib also works very well in patients with CKD. So yeah, there's a specific number of treatments that we could potentially choose based on the renal function of patients.
The next question is, can you talk more about ibrutinib plus Rituxan combination, especially for a Waldenstrom patient with existing RA?
So RA, I can imagine, is rheumatoid arthritis. I'm assuming because it's a common nomenclature. So nothing that I can say with category. The only thing I can say is rituximab is sometimes used in patients with rheumatoid arthritis. I don't have any data in terms of the safety or efficacy of ibrutinib in rheumatoid arthritis in this setting. If I felt that this is the best treatment for a patient with Waldenstrom's, I will make that decision without actually taking into account the rheumatoid arthritis.
Great, thank you so much. Our next question is, in older patients, 65 plus, exhibiting few symptoms and have stable lab tests, would they require treatment?
So, I mean, again, hard to provide specific recommendations, right? But if we have a patient who's asymptomatic and the numbers look good, obviously I will not recommend treatment in that setting.
Thank you. We're just waiting for a few more questions to come in online. Here we go. Our next question is, someone asked about side effects of venetoclax and ibrutinib combination treatment.
Yeah, so ibrutinib, as I mentioned previously, the side effects that we tend to see more commonly are AFib and bleeding. Again, AFib in about 10% of patients, bleeding we see that a bit more often, but the bleeding can be really easily managed. So if we know that a patient is going to have a surgical procedure, for example, we recommend holding ibrutinib for a few days before and after each procedure. And by doing that, very similar to what we do in aspirin with aspirin, and by doing that, we actually minimize the risk of bleeding. Obviously, bruising is increased when patients, if they hit themselves and things like that, then obviously they can have a little more apparent bruise than anything else. But those are more cosmetic issues, much more than real, concerning issues, to be honest. Now, venetoclax, in terms of side effects, will be more, nausea and diarrhea because it's a pill, and some rash as well, and decreased blood counts, specifically decreased white blood cells. Again, in our experience, nothing that has needed to stop treatment because of that. Very few patients needed to have white blood cell boosters. We can use it if we need to, but the rate of use of white blood cell boosters in those patients was very, very low as well. So yeah, those are the most common side effects that I can think of. I mean, I think for venetoclax, tumor lysis syndrome is an important side effect, specifically in patients with chronic lymphocytic leukemia. In Waldenstrom's, we have not really seen tumor lysis syndrome on venetoclax, so that is less of a concern in our population.
And thank you so much. We have time for a few more questions. Just as a reminder to please type it in through the Q&A box on your screen. Our next question is Agent Orange associated at all with Waldenstrom?
So Agent Orange exposure has been associated with the development of a series of blood cancers, and that includes leukemias, lymphomas, and myelomas, and Waldenstrom's being a lymphoma is also included in that list. So I would say yes, I think there has been an etiological, a causal relation. This has been actually acknowledged by the Veterans Affairs institutions. So yeah, I think there is a strong relation there.
Great, thank you so much. Our next question is, are Waldenstrom patients at higher risk of COVID given immune system cancer often associated with lower IgA and IgG?
That's a great question. I mean, we are learning about this, obviously. In our experience, we have not really seen a higher rate of infections in patients with Waldenstrom's. But many things can play a role into that, right? Number one, our patients tend to be maybe more careful than the average population, and that's why they are not, being infected. The population that come to Dana-Farber might actually have better economical resources and maybe, afford not to work or work from home, right, compared to other populations. So, there's a lot of socioeconomical aspects that I don't think we can measure at this time and categorically evaluate at this moment. I do feel that the risk is different from patient to patient. So a patient who's actively on chemotherapy, for example, I think that patient will have a higher risk than a patient that is not actively on chemotherapy, right? So I think that is one thing. If a patient is newly diagnosed, I think the risk will be much lower than a patient who has had multiple treatments for the Waldenstrom's. So I don't think the risk of COVID-19 or any infection for that matter depends only on having Waldenstrom's. I think there are other aspects to the disease or the treatment of the disease that play a role into that. So I don't think there's one answer for that question, unfortunately.
Okay, great. And I think this will be our last question, I think, unless we have another come in. But the last question, and a very important question, is how can someone find clinical trials near them currently recruiting patients with Waldenstrom?
Yes. So, first I want to say that the clinical trials for patients with Waldenstrom's are not too numerous. They're just usually a few. But there's a clinicaltrials.gov website, just like that. Clinical trials, just one word, .gov, G-O-V as in Victor at the end. In that, you just type Waldenstrom's in the condition that you want, and that will give you all the trials open that are accepting, patients with Waldenstrom's. They will give you there who's running the study, who's sponsoring the study, what the medication is, what the design of the study is, what the outcomes of the study are, and also who are running the studies. And typically, there are emails and phone numbers as well there if you want to get more information on those studies. So that, in my mind, is probably the best resource that patients can reach out to. Now, there are other advocacy, organizations like the Lymphoma Research Foundation and the International Waldenstrom Foundation that can also provide, information on clinical trials if necessary. So there are a number of resources that patients can use for this purpose.
Great. Well, thank you so much, Dr. Castillo, for taking the time to talk with us today. This was really informative, and I know everyone on the call really appreciated it.
Thank you very much. It was my pleasure.
Great. And thank you to everyone joining us on today's call. We hope you found the information both informative and also hopeful. We'd also like to thank our sponsor again for making this program possible, Pharmacyclics and AbbVie Company and Janssen Biotech. Please remember, if you have any additional questions or you'd like to be connected with someone else who has been impacted by lymphoma, you can reach out to the LRF helpline at 800-500-9976. Also, at the conclusion of this program, you'll receive an email prompting you to complete a program evaluation. I would ask that you please take a few moments to complete this evaluation, as these are important for helping LRF to ensure they deliver the most useful and meaningful programming to you. And with that, I'd like to thank you all again for joining us, and have a wonderful day.